All right, good morning again. It's Phil Pugh. We're going to go ahead and get started with our quarterly coalition meeting, June 5th, 2024. Wow, has the time flew by. We're halfway through. All right, as usual, we are recording this, so it will go up live on our YouTube page this afternoon. So if you do not wish to be recorded, feel free to hop off now, and then we will get you guys, like I said, a spot where you can view this routinely out on our YouTube page. If you haven't subscribed, please go ahead and subscribe. Like, share, comment, all the stuff the creators say out there. This is our agenda for today. It's our traditional agenda. And we do have an update on the notice of funding opportunity for the upcoming budget periods 1 through 5 from ASPR. So we'll be talking about that today. Obviously, our upcoming events, time for you guys to bring any things to the floor. And then we will talking about our coalition plan review. So we're following our integrated preparedness plan, at least the shell of it now. So, but that's our topic for this month. But as always, we're going to go ahead and get started with our roll call, and we'll start with our hospitals. Looks like we got about 30 folks on, so we'll go start with Anderson.
Eric Brandmeier here, representing Anderson and Community Hospital Staunton.
Thank you, Eric. And shout out to the good folks at Anderson Hospital who took great care of my wife with a recent surgery. So shout out. Moving on to Alton Memorial.
Good morning, Phil. Aaron here at Alton.
Morning, Aaron. Boyd. Hearing no one from Boyd. We'll move over to Carlinville Area Hospital.
Tyler's here from Carlinville.
Gotcha, Tyler. And Fayette County Hospital.
Good morning, this is Tina.
Good morning, Tina. Moving down to Gateway.
Sam's here from Gateway.
Gotcha, Sam. Thank you so much. To our HS cohorts here, starting with Holy Family.
Cindy's on from Holy Family.
Morning, Cindy. St. E's.
Brad's on from St. Elizabeth.
Morning, Brad. How about Breeze? Hearing no one from Breeze. How about Highland? Okay, over to Jersey Community Hospital.
This is Nick and Nathan with Jersey Community.
Nick and Nathan, gotcha. Thank you so much. For the Memorial Conglomerate here, you got myself, Lee French, Sean Eisenhower, Mike Gilbert, and Scott Klosterman should all be here. And for Memorial Chester.
Hi, it's Georgia.
Good morning, Georgia. OSF St. Anthony's. Once, twice, thrice for OSF. Nope. All right. Redbud.
This is Tara.
Hey, Tara. Sparta.
Got Dan here, Phil.
Good morning, Dan. And Touche. Let's see if they jumped on.
Yeah, good morning, Ryan and Jade.
All right. Yeah, we have good folks live and in effect there, as you can see in there with Lee. So awesome. Ryan's doing the gentlemanly thing to do and great leader thing to do and bringing folks by. This is a good opportunity if you want. I think last month we did get an opportunity maybe to give an introduction, but since you got the camera on today, would you like to give a quick wave and introduction for yourself this morning?
Yeah, sure. So I'm Ryan Purtle. I was around at Alton years ago, but now back at Touche in Southern Illinois. And Jade Bashir's here is new, and we'll be covering the EM role at Touche. So yeah, excited to be here and trying to rebuild the program down at Touche.
Awesome. We're glad to have you. Yeah, as Ryan said, he was at Alton and went up to system level at BJC, and now has moved over Touche. This is just awesome to keep you all in the family here. So glad to have you. And we're glad to see new life being brought down there to Touche. Great partners with us. All right, I see Stacy in the chat from Breeze. Gotcha. Thank you so much. We'll move over to the health departments at Bond County.
Wendy's here from Bond County.
Good morning, Wendy. Calhoun. How about Clinton County?
Morning, Phil. It's Brett.
Gotcha, Brett. Thank you. Eastside Health District. Once, twice, thrice. Nope. Okay. Fayette County.
Kendra's here.
Good morning, Kendra. Greene County. How about Jersey County? Macoupin.
Good morning, Phil. It's Derek here.
Thank you, Derek. Good morning. Madison County.
Michelle and Jacob are here.
Awesome, Michelle and Jacob. Monroe County. How about Randolph County? And St. Clair.
Good morning, this is Kara.
All right, we'll go over to our community partners. We'll move down to our emergency response coordinator. Beth, are you on this morning?
Yes, Phil, I'm here. Good morning.
Awesome. Thank you. Thank you. Over to our BJC partners, or yeah, any of our BJC partners on this morning?
Brody
Christian
Ellis.
Hospital's on.
Okay, Brody, gotcha. Thank you.
Barnes Jewish Trauma.
Awesome. Who is that? I thought I heard two voices.
Yeah, Christian Hospital. This is
Jason.
So it was JJ job. Got both of you guys again. So I heard Christian Hospital. Who was that?
Scott from Christian Hospital.
Okay, gotcha, Scott. Thank you. Okay. And I think I heard Jason on too. So
Yep.
and I know
Good BJC representation today.
good, awesome. All right. Any of our EMAs on? I know we got Sam Bierman on. Any other EMAs on?
Just me. Thanks, Phil.
Thanks, Sam. How about MedStar? Good folks from MedStar.
I'm here, Phil. It's John.
Good
So then
morning.
who
John.
would,
I'm next thing.
I'm sorry, who was that? Was that Helen?
Good morning, Helen Sanquil.
Okay, gotcha, Helen. So we got SLU representation. How about Abbott?
I feel Leslie from Abbott is on today.
Awesome. Good morning, Leslie. Thank you. Any of our Scott Air Force Base partners? Hearing none. I do know, just as a quick announcement, I do know that there will be a retirement here soon for Johnny Mack. So if you received any of those invitations for that retirement ceremony, it'd be great if you could show up if you did receive one. For any of our STARS cohorts on this morning.
good morning. This is Rachel from STARS in the St. Louis Healthcare Coalition.
Thank you, Rachel.
This is Brian Marler as well from STARS.
Gotcha, Brian. Thank you so much. Any other STARS or St. Louis Regional Healthcare Coalition members on? All right, great. We'll go ahead and move on and get started. We'll take a quick look at our open tasks or due outs. I think we did have a few things there.
Hey, Phil, this is Rick Wolf. Sorry, I didn't get there in time.
Oh, no problem. Gotcha, Rick. Thank you so much. Appreciate you. Some of our open tasks due outs that we did have that I can cobble from the last meeting was providing update on STARS equipment and supplies tracking during next meeting. So Rachel, we had something, I know there was some conversation about that there. Folks had some questions with regard to if they had an asset and, you know, it needed to be updated. I think Aaron had that question, you know, what was the correct process? Did we ever find out any additional information?
Yeah, we did. So I had forwarded that request on to Leah, who is our grants manager here at East West Gateway, and she is the much more knowledgeable source and actually manages that on the day-to-day. So she should have been in contact with Aaron specifically. However, just in general, STARS does not replace equipment that has gone bad. Like we won't just we can't get an email and just give you something new. It's done in bulk and it's done when the money is available. In terms of supply tracking, we are working on a schedule at the moment to go through all of the caches that have been STARS affiliated in the past to update and ensure that everything in there is functional and up to date. And then that should give us a better idea of how to move forward with potential replenishing activities in the future or putting grant money towards getting new equipment for folks. So that is the update I have at the moment on that.
Okay, thank you so much. And Aaron, hopefully you got your question answered. And if we do have any additional things, I guess we can, if we get something forwarded to us, we will forward it to Leah and you, courtesy copy you, Rachel, just if there's any other questions.
So this is Aaron. So Rachel, who did you say that email should have come from?
Leah Watkins.
Okay.
Just let us know
Yeah.
after this, and we'll follow up with you, Aaron.
Okay.
Yeah. Also, just as a courtesy, it has been UASI season for us here, so she's been working like crazy to get that grant done. So I think a gentle reminder, if you haven't heard back, would be an appropriate step. But she has been working really hard on getting some other stuff accomplished.
All right. Thanks.
Appreciate that. And then for us, it was something about check with IDPH and ASPR to see if the ASPR documentation will remain the same for the upcoming year. Don't have a full answer on that yet. So, and some of that we'll be talking about here at the end of this meeting, at the end portion of this meeting. So without further ado, let's kind of jump into our updates from an IDPH perspective. I don't have anything specific, and I know Beth is up next as well. And I will be talking about NOFO and some grant things that are IDPH related here later. But Beth, I'm just going to toss it to you. Anything from an IDPH perspective or just generally for the health departments?
Good morning. Big news is the measles outbreak in primarily in the Chicago area is officially over. We went through 2 incubation periods with no new cases, so yay for that. We're doing work for planning for the Democratic National Convention and the Republican National Convention. I just had 4 appointments pop up on my email. So a lot of work that's been going on for that in the last year, more than a year. NASCAR race, I think some other people will probably have more information, but as far as public health, really appreciate the EM track. We use that. Still monitoring Essence, but so far everything looks there. As far as the grants, the CRI grants are out. All of the health departments in our region have submitted. So great job, everyone. The FEP grant is out, and I know everybody's working on those now to get them submitted. The last thing I have is there is a access and functional needs training and exercise. Did you guys get an email on that? Did they send out the siren alert to you guys? Hospitals?
Yes, I received.
Okay.
I know I received it. I'm not sure about all the other hospitals. I'm not sure if I just got it because if it was just to RHCCs. So
I got it as well, Phil.
Okay, so Eric got it. So yeah, it did go out.
Okay. All right. I won't talk any more about that then. That's really about all I had, unless there are questions.
Any questions for Beth? Okay, hearing none, we'll move on. Thank you, Beth. So pause for stars.
Yeah, so major updates all revolve around the HPP at the moment. So I'll talk about that, I think, after you do, Phil. I don't want to steal your thunder with all that. Otherwise, we've gotten our UASI grants. All of that was approved by our board. So everyone should be receiving the funding that was allocated to them during the application process. We had, I think it was a great success. We did a new scoring and evaluation project for that, so it should work out well in the future. It gives it a little bit more of a broad scope for understanding where the scores come from and how projects are being funded. We also are working towards our first big exercise next week, which is the Hunter Seeker. I hope you all were able to receive the invitation to register for that. I do believe registration has closed, but I don't know that for certain. So if anyone is interested, let me know and I can see where we're at if you would really like to be added. There's a full-scale exercise on Thursday of next week with topic-specific exercises Tuesday and Wednesday. Additionally, the St. Louis Healthcare Coalition's MRSC is 2 weeks after that. And then another 2 weeks after that, we're gearing up for the DUT, for which you all will be participating in receiving some hospital patients, both via ground and air. And that project is going well and no updates further from that. Otherwise, I think we are all good here.
Awesome. Thank you so much. Anything, I know some of these get conflated sometimes, but anything from a healthcare coalition perspective for the St. Louis region?
No, like I mentioned, all of our stuff was about the HPP grant, which I saw further down on your agenda. So I will let you take the reins on that. I am very interested and curious to hear about how you all thought that went and maybe give some insight at that time.
Sure thing. Perfect. All right. Move over to Remer. Mike?
We had a very busy weekend this weekend at NASCAR, but everything went well. We had a lot of collaboration between community partners. Between HSHS St. Elizabeth, Gateway Regional, and some of our new upcoming EMR agencies that provide manpower to us. We saw a lot of sick patients. We actually went through more medication with patients this year than we have the 2 previous years put together. I mean, we had some really sick ones. Ran into some challenges that we're going to have to address, but I think between Lee's planning for the Remert side of the house and then John Nowak's planning for everything else that we did really good. From what I'm hearing from everybody, they were really impressed at how well we were able to take care of people, and then having other community partners like Sam Bierman, who just jumped in and helped us handle some situations that we needed taken care of real quick as she was doing her role of safety. Was phenomenal that everybody just jumped together. So Lee, you got anything else?
No, I think this was a really good opportunity. I think this is definitely something that going forward we'll put out to the region again and solicit support from the hospitals. It was absolutely wonderful having ED staff in the field hospital so that EMS staff could do EMS-y things. We had a very busy Sunday. Some of us are still recovering.
Yeah, if you could have saw their faces when Monday morning when I came in, I was like, oh, rough weekend. So I cannot say enough about Remert in a lot of these special events. I know you look at some of these events around St. Louis Metro East, and you would think that all of this is all paid for services and all that type of stuff, but it's not. We have great organizations out there putting in volunteer work, and we could always use support for this level of work. I mean, while we probably transported or had more visits last year, I think some of the acuity of this year's visits may have been a little higher. I don't know, but there's always something. I mean, you put, a couple 20, 30, 40,000 people on a hot day out there, you never know what you're going to get. And those guys really performed professionally and provided great care and got folks to where they needed to. Really out there saving lives, at a fun event. So thanks for everything you guys do. Yes, go ahead, Mike.
Hey, Phil. So Brad Perry mentioned on the last meeting that he doesn't have confirmed numbers, but he actually thinks that we are pushing more 60,000 this year.
Oh, there you go, right there. I know some folks felt it in the traffic, but you guys felt it out there on the field. So thanks for everything you guys do. And if you want to volunteer, or folks that would like to volunteer, and again, you don't always have to be clinical to help out, shoot me, Mike, or Lee an email, and we'll get back at you. We appreciate you. Thanks.
Hey, Phil, I want to take that one step further. Me and Lee just talked about this. If you want to get an idea of what we do when we're out there, let us know, and we can get you set up where you can come out and see us for a couple hours or for the day, whatever you want, and just kind of see what we do, so that you have a better idea of what we're doing when we talk about setting up an alternate care site out there at NASCAR or IndyCar or any of the other stuff we do.
Indeed. All right. Okay.
Hey,
So
can I interrupt real quick?
sure. Yeah, go ahead.
So for you guys that were working, and I know I got this information last year for data purposes, can you give me a number of patients that you saw or touched, and how many patients that you took care of in the on-site hospital that did not have to be transported to a brick and mortar hospital? We got that information last year, and I think that's a great number, and it shows a lot of value in what you guys are doing.
Beth, we'll work on that. There were some issues with EMTrack this year, and so we're going to have to, some of those numbers are going to have to be manually entered or tallied up. So it may take us a little bit longer this year, but we'll get those numbers to you.
Yeah, no rush. I just mentioned it before we move on to our next incident. Thank you.
Hey, real quick, hey, it's John. Can you hear me? Because I'm kind of trucking down the road.
Yep, I got you loud and clear, John. Go ahead.
Okay. Pat, I will have that final report done on the overall. Just don't hold me to these numbers, but these are numbers that I'm digging to get my report done. There was 127 requests of some type. Could have been from needing to find a cooling trailer to a Band-Aid ice pack to stroke, chest pain. Anyway, there was 112. There were 57 transported to the mobile hospital. That I believe there were 37 that were actually treated for some type of something inside the mobile hospital. There were 8 transported to different hospitals just Sunday. There were 4 critical, one being a stroke, one being a STEMI, and then we had one that was kind of in and out of consciousness that we believed that was a head injury. He didn't even know if he had fallen or not. And we had a child, a 7-year-old child that definitely was confirmed head injury once he arrived at Children's. So 2 head injuries, a stroke, and a STEMI that was critical, along with the other 4 that we transported.
Thanks for that, John. And yep, I know we'll follow up with the final tally to you, Beth.
So this is Sam. Just real quick, I am just going to echo everyone else's sentiments that Remer did, and MedStar as well, did a fantastic job this weekend. I know at one point we couldn't even dispatch quick enough for all of the reports that were coming in requesting medical, whether it be just transport or being transferred to the mobile hospital. It was phenomenal. So great job by everyone involved.
All right, thanks for that, Sam. All right, update on the upcoming budget period, BP 1 through 5, 25 to 29. I talked to you guys last month about where we were at the time, and we were kind of stuck in no man's land. And that was, I mean, glaringly apparent because we had not seen anything from ASPR at that point in time. But since then, IDPH received the NOFO from ASPR on or about the 19th of May. So a couple weeks after our last meeting. And when they received it, they were given 30 days to submit with a suspense of 6/18/24. So in 13 days, they have to have their application back to the feds. And I mean, generally speaking, that's a relatively short time frame. I don't have another meeting with IDPH until next Thursday, which is the 13th. So traditionally, what I'll say is this normally happens around April timeframe, where they've reviewed, they have the NOFO and to see if there are any changes from year to year, because these are again in 5-year increments. But normally around April, the feds have, if they've made any adjustments or anything, by that point in time, we get a chance to take a look at it and provide comment on, what the changes are and what that means, how that impacts the healthcare coalitions. So we haven't had any of that. So we're about 2 months removed from what is a more traditional timeline, at least since I've been here. Okay. It kind of, I don't want to say it puts us behind the 8 ball, but it does, it speeds things up dramatically, which kind of slows things down, if that makes any sense, because what's going to really happen is it's going to really snowball us to try to get all our ducks in a row. Yes, we'll be working hard, but it's a lot of things, and normally this will push all of the deadlines to the right a little bit. So that's what I mean by slow us down. So we received that next week. When I say we, my peers at all the RHCCs and Healthcare Coalition leads received it on the 21st by email from IDPH, and I just started reading through it to gain an understanding of what's to come. So some key or some notable items that you'll see going forward. The Mercy exercise will continue. So the medical response surge exercise, that will continue, it looks like, throughout year over year. There is an increased focus on cyber. There is a requirement for the coalitions to participate in a patient move exercise with their FCC counterparts. So for those of you who are not familiar, the Federal Coordination Center, when we normally have like an NDMS incident, so a hurricane happens in the Gulf, we need to move patients into a safe location. We traditionally have done that. Since I've been here, we've done 3 full FCC exercises, but that's not every coalition. But I would suspect that we will have to complete at least 1 during this next budget period, and that is, again, that's a full patient movement exercise. There's going to be a requirement for a cybersecurity exercise. I know that you read stuff in the paper all the time, or you probably got an ad on your phone for whether it's some form of tracking of your personal information. But as we know, being a part of healthcare, that is it has been and it is an increasing threat. Whether it's patient information, folks that are subject to ransomware, and non-hardened durable medical equipment. So medical equipment that susceptible to being hacked, and I'm using air quotes out there. So there will be a requirement for a cybersecurity exercise and a non-cyber extended downtime exercise. Okay, a non-cyber, downtime exercise where you've lost. They say non-cyber, so let's say it's not a malicious logic or some form of hacking, but let's say you've lost access due to you lost access to electronic health record and the things that you can do normally, but maybe that's by physical means. So I'll just use the earthquake because that can rip apart lines and cause outages or what have you. So those are some key things that I noticed. There are plenty of other things in there. That document, and I sent everyone a copy of it along with these slides, meeting minutes, etc. So the email that I sent you today has a copy of this. It's it's pretty long, so it's I'm not gonna expect or ask everyone to ensure that they've read it, but I mean this does give you guys some insight as to what's what. Okay, like so some of these things we're not, we don't just make up. Yeah, as Aaron says, 97 pages long. There is a section there where it kind of gets really light reading. The font is really big, so it's not, it's not a novel in that regard, but it's a lot to digest. I think it's best to just be transparent with everyone so you can see how we formulate some of these things and what kind of drives what we have to do as a coalition from a leadership perspective. Some things, aren't all our decisions. Some things we just kind of got to follow in suit, and to a certain degree, that's a good thing because, what we have to do is the same that the folks on the opposite side of the river have to do, and this gives us an opportunity to collaborate together and make those things happen. Okay, so. But there are instances in which, maybe the federal lens may not be as attuned to what we need versus what we have to do. We may need to focus on one specific or two specific things because this is what, like we said, mental health. I think that was one of the things that we looked at as a portion of what we need to get done. When I look back at our IPPW work, our integrated preparedness planning workshop, things that we outlined in those goals, one of the top things there was our cash assessment inventory. Like it doesn't tell you that that's something that you have to do, but we know that's something that we have to do because of the status of our equipment and supplies. So sometimes we may have conflicting priorities, and it's our duty and responsibility to kind of deconflict all of that and get us into line. Okay, so this is pretty much normally the process. I kind of described this earlier, but once IDPH has fully deciphered it, we have that meeting next week. I'm sure they will ask us what we think. We'll provide our commentary, but then that churns out a deliverables and milestones document called the scope of work. So that basically details, what you have to have done by what deadline, etc. Okay. Now, what the ASPR did in their wisdom and some of their feedback that they've received from the states is that they've somewhat loosened the reins on specific deadlines, and they are trying to give you more of the budget period, the entire 5 years, to get some things done. So they may not, like in previous years, it may say you have to have your HVA done by April of each year. You probably won't have that specific detail there, but it will say you have to conduct an HVA annually, and that allows, or review your HVA annually, or conduct XY assessment annually, and then we're given the latitude to make those, make those things happen. So that's a good thing. They did remove some of those, hard line requirements. We'll see what happens in the deliverables and milestones in the scope of work. There's a lot of readiness assessments that are there. I kind of just pulled some out of the document. A few things of note. I mean, the risk assessment. This looks more of a state level assessment here. This risk assessment. It looks more like it is a state level assessment versus a coalition level assessment. But I will tell you this, traditionally, if the state has a requirement, they levy that down to the coalitions and then they pull up that information. Okay. So if the state has to do it, then they'll give it to all the RHCCs, coalition leads to make it happen at the, at the coalition level, at the regional level, and then pull that information up. So we'll have to see what that entails. HVAs, as normal. We have had discussions in the past about extracting our HVA. And when I look at, when you take a look at that section, it does detail a few more things in there than we've kind of done in the past. Now, that said, like when I look at our HVA for Memorial, Belleville and Shiloh, it looks more in tune with what the feds are asking for. But traditionally, what have we had when they said HVA? We basically have either had the SIMP model and hospitals updated it and it consolidated, it did the risk probability index and put that all into a singular document. But there was no context behind it. They are transitioning and they're asking everyone to move over to the Risk 2.0 tool. If you didn't see, a couple months ago, we talked about the risk tool. At BJC, we have transitioned to that. And we did establish when we started to do that Jason Lee, somebody help me out. I think last summer timeframe, maybe fall, when we initially did our version, we created a coalition version of that, and we discussed it. I think in October, around the October timeframe last year, October, November. So we are going to have to transition to the Risk 2.0 tool. So that's going to be a change from what we've done. So we went from SIMP to the Kaiser Permanente model, and now we're going to have to move over to the Risk 2.0 tool. Again, the readiness assessment, there's specific things that are there. So you have a risk assessment, some readiness assessment. This will all be new, so hopefully they'll provide us some context as to what they're looking for specifically. We worked through the supply chain integrity assessment, and we did that via survey from the coalition, and we provided a copy of that out. But there are some more finer details look like that will be there. So we'll have to see what that does. Something is pretty new, the workforce assessment across your coalition. I don't know how we're going to do that. I would presume it wants to look at, what staffing looks like and when you have staffing crunches and how much agency you're using and a few other things, but it'll be new for us to do. So we'll be looking for some support from IDPH and ASPR in how those are conducted. And all of these are not annually. I don't have all the dates in here. And again, wouldn't do that until we've gone through the scope of work and had everything from IDPH. So we'll get you'll get another refined version of this later. Again, cybersecurity assessment. That one seems to be kind of okay. I think we can do some of that via survey throughout. And the extended downtime, and we talked about that, what that assessment is. So I don't know what that assessment is going to fully entail. It's got a few notes in there, but again, more to come when that scope of work is there. I see what Jason said the St. Louis RHCC discussed adopting the ASPR 2.0 toolkit and metrics, and he put a link in the chat for everyone to see there if you want to take a look at that. If you didn't get a chance, if you weren't on any of the calls where we discussed that in the past. And if not, it's always on YouTube. You can kind of go back. So plan, implement, it says they had a section in there regarding plan implementation. So looking at strategic plans, readiness plans, response plans, and continuity and recovery plans. So there, I put some specific things underneath there. So in our strategic plan, there's priority management, policy approach to regulatory challenges, and community impact engagement. So as we've been working on this integrated preparedness plan, that's my view of what's going to fulfill this strategic plan. So it's going to touch multiple places and spaces, so to speak. And you guys have helped along the way. So more to come on that. We're just going to continue to plug away there. And this readiness plan, addressing strategic priorities, plan implementation, HCC development, we're trying to wrap that into this singular plan as well. Now, the response plan, COP, and all of that type of stuff will reside in more traditional plans, at least from my perspective. One of the things that they're kind of championing this year is the sharing of clinical knowledge. Now, not sure specifically how we do this on the St. Louis side, but here, a lot of these things we're already accomplishing, and I think we just really need to document. So quarterly, as you guys know, we have like the trauma committees, we have the EMS meetings, we have, today we've got all those meetings going on, and we're sharing this information. We're sharing that clinical information across things. So we're doing a lot of this, but we're going to have to codify this in a plan that kind of that details how we do that. Again, I think some of that can be in our integrated preparedness plan, and we'll just need to have specific sections for it, et cetera. Now, the continuity and recovery plan, we have talked about this again in the past, and in the past, we have, I believe, what we need to get us through, especially being that we are not and when I say we, the Healthcare Coalition itself, because the Healthcare Coalition itself is not a business entity in and of itself. Memorial, as the RETC, has been the fiduciary for, and by proxy through BJC, has been the fiduciary for our grant, but we are not an independent business. The Hope Coalition is not like the Mesh Coalition over in Indianapolis or other locations that you may have seen across the United States. So what they're asking for in some instances doesn't fit directly what we do, but we're probably going to have to pull what we have out. And we've discussed this in the past, what we have in our emergency operations plan, the continuity portions out of that, and place that in its own separate plan in of itself. So that's something that we're going to just have to probably do. Again, looking to see what they're going to put in the scope of work, and that will give us the specific details. But since then, we've been fine with what we have. But I do suspect with all the downtime recovery operation things and verbiage that they had supporting that it will have to be its own plan. Just really quickly, upcoming events, and we're going to continue on after this, and we'll open the floor to discuss other things. I just want to chomp through a few things. Upcoming events, we've got the D-Day, Normandy, June 6, 1944. It is the 80th anniversary of that. So there are all kind of memorials going on and around this week. So thank you to that generation for getting us through. And if you see, or if you have anybody who's still alive that served in World War II, don't forget to thank them. Fiscal year is coming to an end, 30 June. So for those of you who are still spending your money on your subawards, please continue to do so. We still have scratched the Mercy exercise from the July 10th, and we still have not found a target date for that. We'll discuss here in a second about that as well. We got some decon courses on the horizon. I don't know if these are all of them, but September and October, we've got courses coming up. And again, project submission deadline, November 15th. So that won't open up until 1 July. So we will send out an email with that link when that's open. So be on the lookout for that. All right, I'm going to pause here, and I want to open the floor up just generally. I know there's a lot of information, especially with regard to the NOFO that I provided. What questions do you guys have with regard to that, to the upcoming changes, or any questions? I will say that funding wise, it looks like the state is getting the same amount of funds it got from the previous the previous year, less 300, around 300,000 when I did take a look at that. So looking year to year, about 300,000 less. And if I were to take that and extrapolate that to what we received in previous years, because I have no idea how much funding we're going to receive, but I would expect that we'd probably still receive somewhere around 550,000 for our coalition. So we'll see though. I don't know what that number is. If anybody had questions regarding that. Anything? Any questions? Okay, not hearing any questions yet. If you do pop up one, just raise your hand or shout out when you get a chance. But I wanted to take a quick look because this month, as we take a look at our, our strategic planning, this is part of our integrated preparedness plan, as we put our quasi Gantt chart out there, we are in, the month of June. We're in the month of June, and this is the month where we discuss plan reviews, etc. And then should be transitioning to the Mercy for next month, all those type of things. So with that, I think there are a few things that are going to be, challenged with this, with the delay of receiving the NOFO and not knowing what's on the horizon and what's going to be required in BP1, which would potentially change our calendar kind of going forward. So we have already canceled the Mercy. We do have plans, right? We do have some plans that we have to, kind of sign off annually that we have reviewed, or if we made any changes to them. And we normally do that through the first couple months. We've done this for the last 2 years. We make it through July and August. And then in the September meeting, we would normally have a planned vote. And see, we got that right there, planned vote in the September meeting. So we can, yea, verily, I say, these plans are how we will move forward. But I'm not sure we're going to be able to do that this year. So again, traditionally, 1 July through 31 August, and then we approve those plans at that meeting. Can we do that now? I have no idea, because I have no idea which plans are going to be required in this upcoming year. I think there will be a requirement for a patient movement plan and then an exercise of it, but I don't know that yet. I don't know that. So I want to kind of get some feedback from everyone on what do you guys think we should do? With some things, kind of in flux right now. Do we press forward? Do we just maintain what we have here as a calendar? We have the plans that we have now. We put them out there, and you guys can make comment and be prepared to vote on September for the plans that we do have and we know we have, and then adjust afterwards. Or do we wait for all of it, or some other version of this? Another timeline version of this.
Bill, this is Eric. I think your plan is a good strategy.
Which one? This one?
Moving forward with what we already have, and in the event something is added, we'd circle around and come back to it. I am hopeful that there is a patient movement, basically evacuation plan on the horizon, but we don't know that for sure.
Indeed. And yeah, I would hedge my bets on that one being one of the ones that they may say you have to get done within the budget period, within the next 5 years, or they may, IDPH may say, we want you to do that year one. But okay, thank you for that, Eric.
Bill, this is Tina, and I agree with you and Eric. I think we need to do as you suggested and Eric suggested, so we're not waiting longer and then having a lot to do.
Okay. Thanks, Tina. Anyone else? And I'm not sure, and I'll look for Rachel or Brian or Jason or anyone on the St. Louis side. I don't know what your current battle rhythm is for your plan reviews, et cetera, but have you guys had any conversations around this and, the unforeseen potential changes or additions?
Yeah, we have. To be honest with you, I'm kind of sitting here and in admiration of your calendar. Ours is not nearly as beautiful and hasn't really even made it out of my head yet, to be quite honest. But we talked yesterday, the Healthcare Coalition leaders and I, about trying to focus on now through December. So the stuff that was previously outlined in the HPP, or we could deduce was due between now and the mid-year due dates, and trying to focus on that until we get a little bit more information conveniently, and to complement what you guys had already been talking about. A lot of the stuff that is due eminently is things that we would have already regularly done, like updating our governance documents in the HVA and a couple of other things. So that's our plan of attack at this time. We tend to do our MRSC in the spring on this side of the river. So we aren't running into as large of an issue with that aspect, postponing something that large as you guys are.
Indeed. And in our, I think maybe 2 months ago, with the Mercy, we were looking at either trying to do it in the fall or spring. I do think that that's one of the exercises, and I know we've had some discussions on that we definitely probably want to partner up so we can kind of knock it all out same time, and have something that's more meaningful. Because I know in previous years when it was the Coalition Surge Test or Mercy, they used to have us fenced in. It used to be you had to do it within your coalition, and with the Mercy, they're more realistic with it, to understand that you're going to have to reach out if there's ever really any surge, to expect a delineated line of counties to meet the need is not realistic, because that's just not how healthcare works, and that's not where we have our hospitals. So I do think that that's something that we will probably have to transition over to potentially a springtime. We were trying to front load ours and work and knock plans out year prior, because we had them all listed. We knew what plans we had to have that were new. So whether it was the chemical response annex or what have you, we could write that the year prior, get it signed off, and then go ahead and exercise
Yeah.
it, so again, looking forward to trying to work with you guys on the next Mercy.
Yeah. It is interesting that they didn't outline all of that so specifically in this new HPP. But Philip, a question for you, and what I'm curious about is the response plans and readiness plans, versus like preparedness plans. And I was curious how the Hope Coalition is planning on approaching that, if they're two different things, if they are looking like the same thing to you guys, or if you're going to continue to move forward with all of the surge plans as previously made, in addition to the new ones that they added.
Yeah, I mean, it's a good question. I think it's probably best for us to continue to have our actionable response plans, surge plans, whatever we want to call them. So what all those annexes that we have will remain as functional, in case of emergency, break glass, this is what we're doing, versions of those. And then my goal is when I am able to finally cobble together this integrated preparedness plan, is to meet the needs of those things. So a readiness assessment, I think, should probably, if I'm looking as a planner, my readiness assessment should dictate how other things kind of happen, right? So along with my HVA and all that data that we collect, and that needs to reside in one document. At least the abridged versions of those need to reside in one document that kind of meets the need of all the workforce assessment. That's something, you know what I'm saying? So those things should be leveraged in a grander document, which again, I'm going to say is going to be our integrated preparedness plan, but it should all talk about the strategies, all of those things. And based on those assessments that we kind of are garnering, because every time I hear the word assessment, it truly puts me in the mode of like the cybersecurity assessment. When you look at the CPGs for that ASPR has published for the cybersecurity assessment, I mean, most of those are answered by a question. So there's, 31 different tiers in there, or I won't say tiers, but 31 different areas that are in that assessment that you would have to go through, and it's most of them are yes, no. Do you use multi-factor authentication? Yes or no? Does your organization do that? And then we should be able to look backwards and say, based on these responses, these are our potential gaps. Now, does that make me an IT specialist? And, are we going to have IT specialists that would meet the needs for 5 different healthcare systems across 20 something counties? No, because, we're not all working together, but we at least can understand that, we may have some vulnerabilities out there, and executives and those organizations, should want to know that, yeah, we still do have some problems out there, and that maybe they need to focus some of their funding, education, training, et cetera, on those areas. But that has to come from a document, and it's got to come from somewhere. So again, I do think actionable plans that target specific threats and or scenarios should fully exist, and then the strategic side of this and assessment side should reside somewhere else. And I'm going to try to get it all into the integrated preparedness plan, and I may just keep the title strategic plan, because that's what we had the first time. The one that runs out this year. So, but we'll see. I don't know. It's I would love for them at one of these coalition conferences to show someone a final version of this, because that's what they never do. They give you titles and headings, but they never say, hey, this is what it really looks like. And they leave that up to us, either the state or up to you or I to put together. And that sometimes is very difficult, especially when it's an unknown piece. And a lot of this is still unknown. I know a lot of words to say a little bit of stuff, I guess, but
No, I can relate. It's all good. I appreciate that insight, and I look forward to trying to figure this out together. I think it would be incredibly beneficial for, like I said, for us to, or like you said, for us to try to align some of that MRSC stuff and just generally collaborate a bit more across the river here.
Indeed. Looking forward to it. And we're going to have to get started on it. That's crazy, because it's weird. Again, we're in the middle of June right now, and it's like we just were talking about the RISC 2.0. It feels like literally yesterday, but I'm pretty sure it was October, November last year, and that's 7-8 months ago now. All right. So any other thoughts, folks? Again, these are your opportunities. This is your chance to let your voice be heard. There's a lot of moving parts here that impact everyone, So I don't want anyone to ever feel like either it's just Phil or Lee, and we're just, willy-nilly making up decisions. We really need your input and collaboration to make things not just palatable, not just agreeable for everyone, but functional for us, that's really meeting the need for your organization. And by meeting the need for your organization, we're meeting the need for our coalition writ large. So.
Phil, I would just comment, this is just my head moving. I'm trying to wrap my mind around how they would perceive we would do a coalition exercise on cybersecurity. I'm just gonna say it out loud. I think that's a pipe dream because from cybersecurity incidents that I read about and have visualized, it's not like we're very transparent when those occur. So doing an exercise from a coalition standpoint, to me, from what I've observed, is almost laughable. And I was wondering if you had any insight on that. So,
Well, I mean, yeah, a lot of times you do have folks who can be kind of tight-lipped about those things, not just in our coalition, but I mean across the spectrum. When you look across the United States, not every, you hear about them, but you rarely get the specifics on what occurred. The way I see it, especially when we got a chance to listen to the folks in Vermont, I think it was a Children's Hospital League, correct me if I'm wrong, I can't remember the name of it, but it was their #1 trauma center. It was a great facility. I think we briefed on it. They lost, it was a ransomware attack for them, losing access to electronic health record, a few things. I think over the course of 6 weeks, cost them $32 million for a $75,000 bounty on the ransomware. And they were, one of the things that they did say that initially they were super tight-lipped about it. And they felt like they should have been a little more transparent initially, which makes sense because what you don't want to have happen is for what happened there, go to the next person, next person, next person. So, whatever that attack vulnerability was, whether it was malware, malicious logic in a program, or if it was a phishing attempt, and theirs, I believe, was a phishing attempt, just that simple, an email that someone received. And the sharing of that and how it got out, for me, if I were to recreate that for an exercise, I would really be testing the coordination and collaboration between disparate healthcare systems. So I would just say BJC, OSF, HSHS, and then our independent facilities, their ability and willingness to share. So if we go back to, let me just go back to, I think it was one of these. Let's take a look. Let me see. I thought I had it on one of these slides. I think it's maybe this one. There was a big word. Okay. So here where it talks about response planning. And again, I had to boil this down to look. I mean, it's a whole bunch of stuff under there. But COP coordination, clinical knowledge, and sharing. I put this all into that kind of vein. You don't want an entire coalition. And when I say healthcare system in that regard, not as a proprietary system, I mean the healthcare system writ large across the coalition or multiple ones. A lot of that has to be shared. A lot of that information has to be shared. We did very well when it came to COVID, right? We shared a lot of, this is what we found out, and that was top down. So as things change at the federal level, or things change at the local level, everybody was willing to share what were good ideas or bad ideas, patient outcomes, right? We stopped venting people so soon. So we need to be able to do that same thing with regard to cyber in some way, shape, or form. And I don't know, I don't know what the legalities are, because that's always a question when I conduct or when I complete the coalition assessment tool, what are your barriers? And some of those are legal barriers, or some of those are like corporate or policy things where some folks just like not willing to share. And maybe that's something that we can conduct and then have folks, try to figure out a way to best do that meets the interest of everybody. So, but great point, Eric. Brody, I see your hand up. Go ahead.
Yeah, just to feed off of that, I think you're on the right track as you're not necessarily testing their vulnerabilities of a phishing attack happening. And Capital Region is in Jefferson City, and I'm somewhat familiar. Obviously, they don't want to release a lot of information regarding why and how and the details, but what they were able to tell me was that they didn't understand or really fully comprehend how much stuff is with the internet and data. So, everybody has to eat in hospital. Well, how do you submit those? You can't use, if you don't have the hacker hits like the internet VoIP lines, you don't have phones, you don't have data. Ordering supplies is all then having to be done by runners, and how do you communicate that? They ended up getting, a cell phone tower trailer to augment in their parking lot, but with the way the facility was and the concrete and everything else, they didn't have a lot of reception in the areas they needed to have that set up. Their outlying clinics, same thing, they're completely dark with everything supplies, not able to call into the main facility to make orders, etc. So there's a lot of the logistical supply chain, how do you bill patients, and then, the charge sheets, and then somebody's inputting that. There's a lot of the back end stuff that I feel like can be focused on, of not actually the cyber attack, but the secondary and tertiary effects that occur when something like that happens.
And thank you for that. And one thing, that I think a lot of times when we do talk cyber, right, we do look at the electronic health record, your Epic systems, your networking, emails, all of those type of things, access to files, et cetera, as probably the first target. But I would challenge folks to kind of look at it, when I look at it from a military lens, I put the military glasses back on, you look at your unhardened infrastructure, your durable medical equipment, generators, Johnson control systems, HVACs, da-da-da-da. So those are also instances, we could have, to meet both needs, Eric, we could have a Johnson control systemware attack that shuts down HVAC and you can't get coolant, and we got to have evacuation. So now you're patient transport and your cybersecurity. Maybe we kill two birds with one stone there. I don't know. So I shouldn't have said the two birds with one stone euphemism, because I had to rescue two birds out of my crawl space in my house yesterday. So maybe that's why it came to mind. Let me pause for a second. Brad, I see you got your hand up.
Sorry, I raised that early. I think Brody said everything that I was going to say. Being on the front line of a cyber attack here, afterwards, that was one of the conversations, because we were starting to get requests from people. Would you put a presentation or anything together on what you learned and so forth? And so my conversation went to legal and stuff, and they said, just as long as you stay in your lane. So we'll never talk about, the ransom and how much it was and what we did in those decisions. What we will talk about and plan and so forth is how we responded. And it's just like Brody said, all the things that you don't think of that really became apparent is what should be trained on. And he mentioned the number one thing that we had an issue with was FANS, food and nutrition. And you don't think of that kind of stuff. So I think a lot of people will share as much information as they possibly can to help what it is and how we respond.
Thank you. Thank you for that, Brad. Rachel.
Yeah, I was just going to say that I don't know if you got the opportunity to attend any of the HPP grant, like open town hall meetings, but they did say that you can merge exercise topics so long as you complete the requirements for each topic. So I definitely want to pursue that in some of the MRSE stuff, since they're not having us test specific plans. I was thinking and talking to our team about potentially having an MRSE focused on certain, like pediatric or burn or something like that further on, to encourage the plan review and practice. But you could always do duplicate efforts, and they seemed to be almost encouraging of that in terms of time management too. So I thought that was a positive that came out of the grant.
Indeed, and we definitely for last year for our Mercy, that's what we did, our chemical response exercise to validate our chemical response annex, and so we kind of killed three birds with one stone in that one. So Yes, and we will try to do that wherever we can. And again, that's where the collaboration, right, between both sides of the river can kind of pay dividends. Okay, one of the things I will say this, as an outcome to some of the new focuses, we're going to have to make some, we talked about this a couple months ago, some budgetary adjustments. We got to tighten the belt a little bit on a few things. I think when we discussed last, we still got around $100,000, maybe $110,000 worth of project requests for this year that will be funded, which is good. And we'll continue. I don't see a big problem with that. So that's roughly 20% of the budget going to project requests, or a little more than 20% of the budget going to project requests. But we're going to transition away from a few things that we've been paying for over the course of the last couple of years. One of those being DTN. It's a weather service that we pay for to the tune of about, I'm just gonna say roughly $7,000 a year that we use. We're going to transition away from that. That's going to come out of our budget, which will, again, make room. But one of the secondary things that we're more than likely going to have to, I'm going to say 90% likely that we're going to have to move away from is our AT&T FirstNet phones that we have out there. The Sonums that some of you guys have. We never fully realized the potential, I believe, with that. The goal was to give everybody a phone, an emergency kind of phone that you could have, that the HPP rep could keep a hold of. We'd always have that one number, yada, yada, yada. And it's been okay, but I don't think we're realizing the benefit of it. And it comes at a pretty steep price. So we're probably going to pull back on that. And I believe we'll probably end up with a few here that we're going to centrally hold on to and use as potential kind of a comm package, so to speak. So if an organization is having an issue, let's say they're having cyber issue and they're having phone outages, that we can quickly grab a cache of radios and some cell phones and push out there and give us, when I say us, I'm going to say my staff here, the ability to run our iPads and or phones so you guys can communicate back with us. So we'll probably go from, we're somewhere close to 25, 30 different SIM cards that we have out there. And that's probably gonna pare down to maybe 10. So that's more than likely coming as a cut in this budget. So we're working through that. And what we're probably going to add is, several months ago we had Colby Farrell from GER, Global Enterprise Response, something like that. I can't remember what it stands for, but we displayed a tool that they had for the electronic health record that we talked about using for the field hospital and alternate care site operations. And what that'll leverage us or give us at least the capacity to do is say, we'll use, for instance, let's say Anderson loses capability with, Eric, you guys use Epic, I presume. Epic is down, or whatever it is, and you're talking about like hard broke or ransomware attack, whatever it is, something that they really can't access, and they are 2 days in, and they are now doing everything manually, like our friends over HSHS had to do a lot of work manually. We had to do the same thing, 2014-ish timeframe here at Memorial, but we're gonna try to include that software suite and subscription as a service. So it is cloud-based to where we could deploy that again at the field hospital. So for like NASCAR, we would be able to do that, which would make it a little, and we could use True Healthcare Record for that, and then use EM Track for the transport piece should we need to do that. So should we need to transport folks, but all the folks that we don't transport that get seen, we'd have that. And we could come in and backfill into an organization down at Chester and provide them something that we can run on Wi-Fi, or if their Wi-Fi is down or guest network is down, well, we can provide a cellular supported network out there, and they could still do very similar things. So we're going to look to try to implement that over the next year or so. So we're going to try to get it in this first year's budget if we can. But to do that, we got to kind of squeeze in other locations. And I've given you a couple of those examples of things that we're going to just go away from to try to make room in the budget to get that in. Any questions with regard to that, with the system itself, or any other budgetary questions anyone may have? Okay, hearing none, hopefully at our next meet, I don't think it will happen by the July meeting, so I'm going to predict August is where we'll have kind of a full accounting of what was submitted for through IDPH. Again, I don't, through eGrams for the BP1 budget. Again, I don't think we're going to have any impact on the project requests that we have out there. Again, we're going to be looking more so to our softwares and other subscriptions and things that we're not getting kind of full bang for the buck out. We're going to be moving those out and try to get something in that we know we use. And I can tell you right now, Remert could definitely use the support. They do a lot of work out there. So, and not just not looking at just to reward Remert. I'm looking at it more so as I know that's where we're, where we have challenges, and I know we can make it easier for them, and it can provide us with not only a deployable asset, but something that we could put in place for an extended period of time should one of our hospitals really, really struggle with electronic healthcare record going down. So, all right. Let's see. Boom, boom, boom. Yep. Okay, so we're going to press forward the plans. Oh, lastly, so meeting minutes and stuff like that. So in that presentation, you click on that link there, your meeting minutes, you will be able to download them as well. So you should not have to worry about copies of minutes. What I want to try to do is move away from putting the slides and presentations in an email every month. Okay, and then meeting minutes in an email. As many of you know, this is where we store a lot of stuff on this cloud-based link that's out there. And this is the same link will take you out to review your plans. And it's odd that I'm missing a slide here. So I'm going to pull up that website, and I'm going to share it to you guys so you kind of can see it in detail, because one part that we did not get a chance to discuss was the plans portion. So what we talked about earlier was going forward with going ahead and reviewing the plans that we know we have and then adjusting afterwards. And to do that, you're going to have to go to our plans. You're going to have to go to our plan review folder, and I'm going to quickly share that. So it's going to be to the same location here. So that link will take you there to those presentations, and I will send out an updated slide that has the link that I'm going to show you here in a second, but I have to switch over to share my screen really quickly. And okay, the link that I'm going to provide everyone, I'll throw it here in the chat, and then I will also included in the minutes as well. And Rachel, I see your hand. I will get to you one quick second. But it'll take you to this document here, which is our comment review matrix for our plan. So you see our 24-25 Edwardsville plan comment review matrix. This is where you can download a copy of this. And what I'm going to ask is that you download your copy, and as you review the plans that will be in that folder, right now, the plans aren't in there. They'll be there 1 July. You'll be able to go in here and put in your organization. So this is an example. So Memorial Hospital Belleville, you put your name, contact information in there, which annex or plan that you're reviewing. If you saw an error that needs to be corrected or a change, just put the page number and the line number that it's on. And then tell us if it's an administrative, substantive, and this is like a drop-down menu. So it's not you only have these choices. If it's substantive, that means that it causes conflict with actual policy or law or something like that. If it's administrative, in this example, the word natural spelled incorrectly. So it's administrative change the word from natural to natural as it should be. This is where you put that. And you're going to email that to info@swillhope.org. So this is where, here, I'm going to take that link just really quickly. I'm going to toss it in chat so folks can test that out if they need to test it out. But feel free to go there. And on 1 July, you'll have all the plans that we have established currently and our governance document there that you can read through fully, and you can make your comments as you see fit. Here, we'll incorporate those comments hopefully by September, and we'll brief those comments. Hey, these are the notable changes. This is what we have changed. We want you to be aware of this, and then we will put that up for a vote. And again, it's probably the most formal we are at any point in time during the year. And we expect, or I expect you guys to, give it an honest look and honest feedback, and then we'll change things accordingly. So any questions about that? Okay, and again, I put the info at Swill Hope in the chat, and I will change the slides over and I'll email those back out just so everybody has links to it. So there'll be another email for this. Rachel, you had your hand up a second ago.
That might have been an error. My apologies.
Oh, no problem. No problem. No problem. All right. So any questions? Questions? Okay. Hearing none, we will conclude the meeting here. I appreciate everyone's time and look forward to knocking a few of these things out. Just as a point of note, I will not be here from June 21st through, I think, July 5th. I will be returning. I'll return back to work on I think it's the 5th. Yeah. I will always be reachable via email, but it's my birthday coming up, so I'm going to be out of town. And hopefully not losing any money in Las Vegas. That's my plan. Hopefully not to lose any money in Las Vegas. But the best laid plans don't come to fruition. So, all right, I will talk at you guys next month. So take care.